Good evening, I'm Maria Muro, and welcome to this special edition of Doctors New Orleans. October is Breast Cancer Awareness Month. There are currently over 2.8 million breast cancer survivors in the United States, and every 8 minutes a woman is told she has breast cancer. Tonight, my first guest is Dr. John Colfry, a breast surgical oncologist at Touro Infirmary, and then later in the show we'll be joined by Dr. Ali Sadeghi, a breast reconstruction surgeon from the AR Breast Center. Dr. Colfry, welcome to the show.
Thank you.
I know that with everybody in October, we say we all go pink, and we're all excited to really bring a lot of awareness to breast cancer. But before we get into this topic, I want to learn a little bit about you, doctor. First of all, what is a breast surgical oncologist, and why did you choose this field of medicine?
Great. Well, thank you for having me, first of all. Like a lot of things, it starts out with a really good teacher. I had somebody in medical school who just inspired me to learn more about the biology of breast cancer, and from that one instance I was hooked, and really at that moment that was all I ever wanted to do.
I love it. I love it. And doctor, before, I know you've only been in New Orleans now for about 2 months, but you're originally from New Orleans. So tell me a little bit about your past history in terms of your medical career.
So I grew up about a stone's throw away from here, actually, in Metairie. I went to high school over on Carrollton and Banks at Jesuit. I went to college at Washington and Lee University, and then did my med school at LSU in Shreveport. I did my general surgery training at Atlanta Medical Center, and I did a breast surgical oncology fellowship at the MD Anderson Cancer Center in Houston. So it's been a long journey to get back, and I am very excited to be home.
Well, we love that. We love that you're home. Now, you brought up MD Anderson. I'm glad you did, because, I brought this up before when you and I chatted, is that a lot of people, or women or men who are diagnosed with cancer, think that, they have to go out of the city for proper treatment or to get world-class treatment. I'm proud to say that, I have a lot of doctors who've been on this show. I work with a lot of great medical institutions in the city, and I think folks that New Orleans has the best doctors. We have amazing health care here, and people like you, doctor, who came back to the city to do good things. We're very happy that you're here.
I appreciate it. I'm very fortunate to have trained there, and very excited to be able to bring back some of those treatment modalities that I've learned to the city.
Absolutely. All right, so let's get started. Tonight the topic is breast cancer, something that no woman ever wants to hear those words. You have breast cancer. So what exactly is breast cancer? Please talk to me about that.
So breast cancer starts in the cells of your breast, particularly in two locations, either the lobule of the breast, which is responsible for making milk, or it also starts in the duct of the breast, which is responsible for communicating the milk from the lobule to the nipple. And so those are the two most common places where breast cancer can originate.
Okay, and let's talk about the statistics of breast cancer. Who gets breast cancer?
It's a lot more common than we think. Again, the statistics we've been hearing all month since it's Breast Cancer Awareness Month is 1 in 8 women. So it's very common. And it typically presents in the 5th to 6th decade of life, although we do see it earlier in some women that have inherited breast cancer from their family.
Okay. And so when let's talk about let's talk about it being hereditary. Okay, tell me the difference between, is like a woman who is more prone to developing breast cancer, should she get screened a lot sooner than, let's say, a woman who's never had any family history?
Great question. So, the first thing to remember is that about 90% of breast cancers are actually random sporadic events, and about 10% are inherited, meaning passed down from older generations. So we need to be very thorough in knowing our own personal family history. And it's not enough just to know, well, my mom had breast cancer or my grandmother had breast cancer. You need to know how old they were when they were diagnosed. You need to know the entire family history, from great-grandparents to aunts to children to sisters to mothers. You need to know the entire family history.
So if possible, go through at least 2 generations, even 3 generations, as much as possible.
At least 2 generations, and it typically first-degree relatives, meaning a mother or a sister, those patients are more likely to have inherited a breast cancer compared to second and third degree relatives like a distant cousin
Okay.
or a great-grandmother.
Okay, and let's continue to talk about the demographics. So, what about different ethnicities? Are they more prone to developing breast cancer?
It's a great question as well. It depends on the biology of the breast cancer. You know, we've gotten away from just treating breast cancer as a vanilla entity, so to speak. We're now a little bit more sophisticated at looking at the actual tumor biology. How do these cells behave? Is it an aggressive type of breast cancer, or is it more of a benign type, one that plays a little nicer, doesn't spread as fast? And actually, when we look at racial discrepancies, we see that in the African American race, they are more likely to have more aggressive, or what's called triple negative breast cancers, than some women in the Caucasian race.
Okay. And what about women of Ashkenazi background?
They are also more likely to have an inherited breast cancer. That's correct.
Okay. And do we know why?
I think a lot of it has to do with just sort of the gene pool that they draw from. Honestly, I think they draw from a smaller gene pool, and so they're more likely to have an inherited mutation.
Okay, I definitely want to talk about gene testing a little later. And what about men, doctor? Do men get breast cancer?
Breast cancer in men is rare.
Okay.
It's about less than 1% of all breast cancers. And we typically see men presenting a little bit later than women, just based on the fact that men are not giving themselves self-breast exams, obviously. So they typically will present a little bit later as opposed to a woman. And
are the symptoms the same?
Symptoms are usually the same. In a man, it's usually a painless lump directly underneath the nipple or areola area.
Okay.
And the treatment for it is similar as it is to a woman. The standard treatment of a mastectomy still applies, although depending on how much tissue a man may have, he may be a candidate for a lumpectomy.
Okay, so again, men, if you do feel a lump or anything different in your breast, they should definitely go and get screened.
They should definitely go and get screened. They should go have a physical exam by a clinician, and then the clinician should either refer them to have a mammogram if they have enough tissue, or more likely an ultrasound.
Okay, thank you, doctor. All right, so now let's get into screening. First of all, I want to let everybody know the phone lines are open. I know this topic tonight, breast cancer. I think most of us know somebody who suffered from breast cancer. Feel free to call in, tell us your story. You can talk to Dr. Colfry and just say hello as well. All right, so let's talk about screening, something that is so important because prevention is key to an early diagnosis. So when should women get screened?
Prevention is key, and there has been a lot of discrepancy, especially in the medical literature, talking about screening, mammography specifically. And the Bible of surgical oncology is something called the National Comprehensive Cancer Network Guidelines, or the NCCN Guidelines. Their recommendations state that for a woman at an average risk of breast cancer, they need to have their first mammogram at the age of 40.
Okay.
And then they need to have one subsequently thereafter every year. There was a little discrepancy in the 50 and older age group saying that maybe we can alternate mammograms every other year, but if you read the guidelines, they clearly state that the risks of getting yearly mammograms, the benefit outweighs the risk, and so they recommend yearly mammograms starting at the age of 40.
Okay.
The next natural question is, well, when do I stop? At what age do I stop needing to have a mammogram? That's also very controversial. But if you're a clinician, you need to use your judgment. If you see that a woman has a long period of life left, in other words, they do not have a lot of comorbidities, that may be someone who's 70 who may benefit from extra screening. Whereas if you have someone older in life who has some more medical comorbidities, some more medical problems, then they may not benefit from screening mammography. So it really should be left up to the judgment of the clinician. And honestly, that's what the actual guidelines say as well. Okay,
so the typical screening process, self-breast check.
Correct.
Right, then a mammogram. And then what about MRIs? We hear a lot about, some women thinking that maybe getting an MRI, it would be, would detect breast cancer, I guess, a little sooner than perhaps a traditional mammogram. What are your thoughts on that?
Right. We have to be careful when we bring MRI into the picture because sometimes MRIs can show us things that we may not even need to know about in the breast, and it can cause us to have additional biopsies that we may not need.
Okay.
So we typically keep keep MRIs for very specific indications, one of which is if you have an inherited gene, which we'll talk about in a minute, the BRCA gene, that is an indication for an MRI.
Okay, got it. All right, so now let's talk about the signs and symptoms of breast cancer. Tell me about that, doctor.
Symptoms usually start with just a painless mass in the breast. You know, in my breast surgical oncology clinic, we see a lot of breast pain. I almost see more breast pain than I do breast cancers. But typically, breast cancer starts as a painless new lump in the breast.
Okay, but there are women who feel pain.
There are women who will feel pain, but it's typically not associated with cancer. It's typically associated either with cystic disease of the breast or something like that. But again, typically for breast cancer, it's a painless lump in the breast.
Okay, and what about any changes in the perhaps the skin or the look, the feel of the breast? Does that occur?
It does, and actually it's important when you're performing self-breast exams to make sure you raise your arms over your head so you can see in the mirror if there's any dimpling of the skin. That's another sign that there may be an underlying breast cancer.
Okay, so now if a woman does find a lump in her breast while she's at home in the shower, we hear, a lot of women who've actually found the lump themselves. What are the next steps? What should a woman do?
Right. Women know their breasts better than anyone else, know them better than their physicians. And so there's a tendency sometimes when a woman feels a new lump, there's a lot of anxiety. And that's understandable. And there's some tendency for women to sort of put it in the back of their head and just kind of ignore it. We can't do that.
Okay.
Once you feel something, you need to immediately have a clinician examine you and go from there.
Okay, so now once she is examined and there's a diagnosis of breast cancer, what are the next steps for this patient?
Right, and so again, it's breast cancer is no longer this one vanilla box that we put everything into. Every patient is different. Every cancer behaves differently. Every patient has different surgical options.
Sure.
And so it's my job as a breast surgeon to educate the patient. I'm really, before a surgeon, I'm a teacher. And I really need to be able to educate them on their options.
Okay, so tell me about the options. For instance, with finding a lump, and then I also want to discuss the different stages of breast cancer.
Right. So the options will depend on how large the tumor is, first of all, and second of all, it will depend on the size of the woman's breast. And so from there, we can sort of tease out a couple of options, and there are two big options. The first option is breast conservation, or what's traditionally known as a lumpectomy, where we remove the cancer and a healthy rim of tissue around the cancer.
Okay.
If you choose that option, you have to get radiation therapy. Okay, so that's option number one. Option number two is a mastectomy in some form. There's several forms, and we'll talk about that in a minute. But those two options are really equivalent as far as long-term survival.
Okay.
So a mastectomy is completely equivalent to a lumpectomy with radiation. There is no difference in the two as far as long-term survival goes.
Okay, and based on your practice and your experience, do women typically go for the mastectomy or lumpectomy? Because to me, I think a lumpectomy would be a more conservative approach.
Correct. And with the advent of mammography and excellent screening that we have now, we're catching cancers a lot earlier.
Okay.
We're catching them a lot smaller, so that's really sort of swinging the pendulum towards breast conservation rather than mastectomy.
Okay, so now should a woman choose to have a mastectomy? We have a few minutes left, doctor. I know the show goes really quick. Let's talk about the different types of mastectomy and how a woman, from the mastectomy will go to see a plastic surgeon like Dr. Sadeghi, who will be on after our break.
Correct. You bring up a very good point. It is imperative to have counseling with the patient and to get them to see a plastic surgeon. Recreating a woman's breast after mastectomy makes her whole again.
Absolutely.
And a patient has to know all of these options. To get back to your last question, the types of mastectomy. Different types will remove different degrees of skin and the nipple and the breast tissue. Let's start with a simple mastectomy. So this removes the nipple, the skin envelope around the nipple, as well as all of the breast tissue. Okay. Then there is what we call a skin-sparing mastectomy. And that involves an incision around the nipple, and basically we tunnel in all directions completely around circumferentially the breast and remove the tissue through that incision, leaving all of the skin envelope over the breast, and that allows for a very nice reconstruction.
Absolutely, and obviously using a woman's natural tissue.
Correct.
Okay, and so these type of mastectomies, what is the success rate of the cancer not coming back in the future?
Right, and the success rate, again, we're removing all of the tissue, and when we're in the operating room, we think that we have removed all of the breast tissue. Can we ever be certain 100% that we haven't left a microscopic cell in the breast? No, we can't be 100% certain. So typically, it reduces your chance of recurrence of a breast cancer to about 5%.
That's a very low number.
So it's pretty good.
Okay, and doctor, so after a woman undergoes the mastectomy, I know that you work with, with a team of surgeons at Touro, and I know that you also work with Dr. Sadeghi in terms of really providing a woman who's going through breast cancer a multidisciplinary approach. Can you kind of tell me a little bit about that, please?
Sure. In 2015,
because you have to communicate.
Because
at the end of the day, it's all about the patient and making her feel comfortable, right?
In 2015, multidisciplinary breast care is the standard of care, and the top institutions in the country, MD Anderson, Sloan Kettering, they sort of defined this approach to the patient.
Absolutely.
And so having the entire team, not only the physicians, but also psychologists, rehab people, it's so important to rehabilitate the entire patient.
Doctor, we actually have a caller for you who has a question. We have Dave. Good evening. How are you? Do we have Dave on the line?
Hello?
Yes, hi. You have a question for Dr. Colfry?
Yeah,
Sir?
hold on a minute.
All right, we'll give you a few seconds, sir. Do you have a question? Yes, do you have a question for Dr. Colfry?
Yeah, I had a mammogram, and they did what else? A mammogram and an ultrasound, and
Yeah. All right, Dave, we're having some issues hearing you, so we're going to have to let you go, but you can definitely get Dr. Colfry's number at the end of the show. All right, so Dr. Colfry, this has been a lot of great information. Again, I love the fact that you work with a team, and at the end of the day, it's all about, patient-centered care and delivering the best care and outcomes to your patient, and I'm excited that you were here tonight.
Thank you
so
so
we're going to
much.
thank you so much.